The presentation outline first. I'm going to review the different types of clinical syndromes that we see in demyelination in kids, both monophasic and relapsing, and talk about the imaging findings in those. Then talk a little bit about some mimics of demyelination that are other inflammatory disorders or other non-inflammatory disorders. Talk a little bit of how you can try to integrate spectroscopy and ADC into your clinical practice, and then talk a little bit about some advanced imaging research techniques that are being used in this population, and if there's time, I have a case at the end. So I did list in the handout a bunch of different references, and this particular reference is in there. The important thing in understanding this is I think you have to think as a clinician and a neurologist when you're actually approaching the imaging findings. And part of it is understanding that there's sometimes a first attack of the demyelination, and that can be associated with certain entities, including ADEM, transverse myelitis, optic neuritis, and neuromyelitis optica, which I'll refer to as NMO for this talk. But then the child can come back with further relapses and recurrences of the demyelination. And then that segregates it into more different types of diagnoses, including recurrent ADEM, multiphasic ADEM, multiple sclerosis, which has its own definition, particularly understanding that the dissemination of the lesions occur in space and time similar to the adult entity. And then you can also get relapsing NMO. So this is a very important slide to just understand the overview of the different syndromes and clinical entities. Now, focusing on pediatric MS, it is similar to adult onset MS. Children tend to have fewer lesions. They tend to have fewer enhancing lesions. They can present with ADEM, which is not typical in the adult situation. And the MS diagnosis does, again, require dissemination in space and time, which is similar to the adults. 30% of pediatric MS patients also have cognitive impairment. This was a study that actually compared lesion distribution using a voxel analysis in between pediatric MS and adult MS. And what you can see is that the distribution of the supratentorial lesions is actually very similar to the adult, but perhaps less in number, while there seems to be more brainstem lesions in the pediatric cases compared to the adult distribution being similar. Also, in kids, we do see more of a female predominance than male. That actually becomes less of a difference when you go younger in age in pediatric MS. Other susceptible risk factors for pediatric MS include the HLA-DRB1 genotype, previous infection with Epstein-Barr, vitamin D insufficiency, and children with normal MRI are likely to have a monophasic illness. So this is a spectrum of lesions that we see in pediatric MS that are very similar to adults, where we see periventricular lesions, pericallosal lesions or dots of fingers, and also some cortical lesions. In terms of post-contrast imaging, we also see different types of enhancement, solid enhancement, complete ring enhancement, incomplete ring enhancement, similar to adults. What I want to point out, though, is that the T1 imaging is very critical, and why that is. I'll show you some evidence-based data later on. But looking for the lesions that are very low on T1 or the black holes is a critical part of the imaging analysis. Also, we do see progressive atrophy, and this is the same patient imaged at multiple time points in our pediatric patients. So I have this reference also in the syllabus, and most of the work I'm going to talk about, or things I'm going to talk about, are going to actually refer to this study, because this Canadian pediatric demyelination study was one of the biggest of its kind, in which they followed 332 pediatric cases that presented with an acute demyelination syndrome, and they were followed prospectively with multiple serial imaging time points and clinical evaluations. And because of that, we actually get a good sense of what are some of the findings that we see that are mimics of demyelination, and I'm going to go into that details. But then how many of these kids actually developed MS, and how many of them actually just really had ADEM, and I'm going to go into a little bit of this all of these kids did have the extensive evaluation, and this is also in the syllabus, which includes a lot of different types of screenings for infection, endocrine, mitochondrial disorders, rheumatological disease, because of the differential in these types of demyelinating lesions. Now, in terms of ADEM, it is a diagnosis that has multiple different components, but the thing that I want to point out the most is that ADEM must include the finding of encephalopathy. And this is a clear clinical indication that distinguishes ADEM from other entities, as listed right here. Now, in terms of ADEM, we do see lesions in the deep white matter, internal capsule, corpus callosum, callosal periventricular white matter, and this is similar to what we see in MS, but there are differences. When you look actually at lesion count from this multi-site study, which had a ton of patients, we see that the most common lesion actually is deep white matter, not pericallosal or callosal, which is different than adult MS. And so this is just something I want to point out. Gray matter lesions do occur. Now, when you look at, this is an example of a patient with ADEM, a pediatric patient with MS, you look at that and you're like, well, it's really obviously different. But when you look at, because you can see that there's a lot of indistinct margins of the lesions as opposed to the MS lesions are very, very clear. So it should be easy to distinguish these two. And then also, we see a lot of gray matter involvement, and these lesions can resolve within a year of time, which is not something typical that you would see in MS. But the reality is that's not the case. This is an example of 12 different pediatric patients with the diagnosis of ADEM, and you can actually see how varied the lesions are when you actually look at these 12 different patients across the board. And this is at the level of the brainstem, and then going up higher up supratentorially. Again, the same patients, 12 different patients presenting with acute ADEM, and the lesions are across the board. Some of them looked indistinct, some of them are gray matter, some of them in the periventricular, some look distinct, and others looked indistinct. And even when you go higher up, you see the same thing. So I can tell you I see these trends, but in reality, it is the imaging findings are heterogeneous, especially when you're starting to compare and think about to MS. Now, if we actually try to come up with some commonalities, this is probably a very good list of them. In ADEM, ADEM tends to be bilateral and asymmetric. It tends to involve white matter greater than gray, but usually both are affected. Deep white matter lesions are greater in number than periventricular, both supratentorial and infratentorial, different size lesions, variable contrast enhancement. So it's all over the place. And if you actually now try to compare this in terms of what we see with pediatric MS, this is a nice example of a child that presented with ADEM, then the lesions resolved a year later, but then the patient came back 2 years later and has the diagnosis of MS. And on the follow-up, it now has chronic MS with multiple lesions. So how do we make sense of this? So if you go to the data from this study, which has a ton of papers associated with it, and actually look at the patients that they followed prospectively that ultimately had MS versus ones that had the diagnosis of ADEM, the lesion that really sticks out is the periventricular white matter lesion, and this with a very high significant p-value. But nothing else is really that different. Even when you look at the gray matter, I showed you that example. It's gray matter, it's got to be ADEM. That's not the case. If you really look at the study here, they didn't find a difference. So it's really the periventricular white matter lesions that are more common in the MS patients who develop MS as opposed to the ADEM lesions, and I think that's a critical finding. What's also interesting is what type of periventricular lesions they are, and this is a Kaplan-Meier curve, which I tend to see more in my brain tumor type of stuff, but this is actually the probability of developing MS. And if you take the periventricular white matter lesions in this study and look at two characteristics, just the presence of the periventricular white matter lesions on any sequence, and then the presence of hypointense T1 or black holes, you can actually see this probability spread out. And this here is if you actually see both entities, that the prediction for MS is very high. So if you have a pediatric patient who presents with ADEM, they have periventricular lesions, and some of them are dark on T1, they're going to get pediatric MS. And also, there is data to suggest there's an age association. So if they present with a lesion on T2 and they're greater than 11 years of age, their risk of MS at an ADEM presentation is about 3% versus a non-ADEM presentation, which is basically the encephalopathy. If they present encephalopathic and looks like ADEM, their risk of MS is 3.3, and if they present as just with non-encephalopathy but with these lesions, their risk for MS is 28%. And all this data really came from this study. So there are warning signs, though, and this is why I'm spending a lot of time on the clinical history, because this really dictates the imaging. When you see progressive neurological deterioration, it is not typical of MS. You want to think of leukodystrophies and mitochondrial disorders. If you see peripheral nerve involvement, that's not typical of MS. You want to consider Lyme disease. Transverse myelitis also is more consistent with a monophasic illness. If you see optic neuritis with transverse myelitis, you're going to want to think about NMO, which is a pretty rare diagnosis. Now, NMO basically affects multiple areas of the brain, particularly the endocrine area, the pituitary area, the diencephalon, but also these patients get hiccups. And why? Because they have involvement of the area postrema. So their clinical entity has some discrete features. And the diagnostic criteria includes optic neuritis, transverse myelitis, and then also this NMO IgG seropositivity, which is a relatively new marker that has just come out that's really improved the diagnosis for these patients. Now let's actually look at some images. So here we have a patient with NMO that has actually optic neuritis that you can see on the T1 post-contrast fat set and also on the T2 fat set. But there's a very characteristic finding of the transverse myelitis. It involves the anterior horn, and I'm going to show you some differentiating examples. But then if you look up at the area postrema, you're going to see some signal abnormalities. So you really have to read these studies with the clinical syndrome in mind and talking to neurologists, because you will miss some of these lesions and you can potentially miss this. Well, this is an easy diagnosis now. They can send off that blood test and they have the diagnosis. Now, that area postrema lesion can be very subtle, but is real. You can see here on the coronal T2 and then also on the sagittal T1, and this is the lesion that supposedly causes the hiccups. Also, the area that tends to be involved, which is not typical with some of the other entities, is the area around the hypothalamus. This is, and the third ventricle. This is another area that's involved in NMO and very characteristic. Also, the transverse myelitis that's associated with NMO tends to be diffuse, as I showed you before, involving more of the anterior areas, while MS is going to have focal, distinct lesions and tends to involve the more posterior areas of the cord. And this is a nice study that actually looked at the distribution of these lesions in MS, and you can see most of these lesions are actually posterior as opposed to the NMO lesion, which is more anterior, involving the anterior horns. So the location can help you with your diagnosis, particularly in pediatric MS. And this was their data that actually showed that the posterior lesions were more common in pediatric MS compared to the other areas. Now I'm going to talk a little bit about mimics of pediatric demyelination and how you can try to integrate diffusion imaging and spectroscopy with your differential. But again, let's go back to the clinical presentation, because this really makes a difference. In terms of how they present can actually dictate the different etiologies. So if it's a very hyperacute onset, you're going to think more trauma, toxins, acute demyelination. If it's acute to subacute, you may think of infectious etiologies, malignancies, vasculopathies. If it's insidiously progressive, you're going to think of metabolic disorders, vitamin B12. And so the clinical history, again, is very, very important. Now, from that study I told you of the Canadian demyelination, the acute demyelination prospective study, they actually had, these were all the patients here that fell out, that did not end up having either ADEM or pediatric MS or NMO or clinically isolated syndrome. And you can see the differential here is pretty extensive. There's stroke, there's lupus, there's migraines, lesions, mitochondrial encephalopathy, cerebellitis, and then tumors. And this is real life. This study makes sense. And this is just from their paper, just showing the example of the brainstem infarct of a child that came in that looked like an acute demyelinating syndrome, but the imaging ruled it out. This was an example of one of the sarcoidosis cases. This was a cerebellitis. These were the actual tumor cases, including DNET, diffuse glioma of crossing the corpus callosum, and a PXA lesion. This was an example of their lupus case that showed characteristic white matter lesions, primary CNS vasculitis, and also sickle cell disease. And this is also in your syllabus, but there are key MRI findings that can be a red flag that you're not dealing with a demyelination syndrome. And this paper really nicely shows those different entities and what particular diagnosis they ended up with. So the imaging really can help with the differential. Now, one case that I wanted to spend a little bit of time on is one particular case that I saw when I was a junior attending at LA Children's, which was the first case I've seen of this entity of acute necrotizing encephalitis, which was a diagnostic challenge for myself and also for the clinicians taking care of this patient, because it looked like an encephalitis or ADEM type history. And this particular entity involves bilateral thalamo-tegmental involvement. It's usually associated with a mild antenatal illness, and it can actually be, they can present very, very sick, like in a coma. They show up in the ER and they're in a coma. And it's thought to be related to an immune-related inflammatory response rather than something infectious or even metabolic. And the hallmark is petechial bleeding in the thalamus. And I didn't make the diagnosis initially when I saw this case, but I learned from it. And I haven't had one yet, so, but hopefully this will be a good learning process for you. So here you can see the very bilateral symmetric tegmental involvement of the brainstem. You can see the bilateral thalamic involvement and also the white matter involvement in the centrum semiovalli. Now, when you look at the T1, this is the hallmark of the petechial bleeding. It's bright on T1, and I don't have the CT image, but it was not very bright on CT, and that's a hallmark of petechial bleeding. You won't see it on the CT image, you're going to see it on the T1. And we also had done spectroscopy, and there was a big lactate peak. Now, I did find some studies about looking at diffusion imaging and trying to differentiate this acute necrotizing encephalitis from ADEM. So I thought I would actually look at this. And in this paper from Journal of MRI from 2000, they actually did look at this entity and over time and found that there were changes in diffusion. Now, I think that the diffusion signal is complicated by the petechial bleeding, so you have to keep that in mind. But when they compared it to their ADEM cases, they really felt that there was a difference in the course of the ADC. And if we look at their data, they found that the ADC was elevated in ADEM and then decreased over time, while there wasn't much of a change in the necrotizing encephalitis, which was on the lower end. So we did look at actually the ADC characteristics in our Pittsburgh demyelination registry. We found 12 cases over the last couple of years that fit the diagnosis of an acute demyelinating syndrome and the diagnosis of ADEM with follow-up. And we actually found that most of our cases demonstrated high ADC, with one case that had both and one case that had restricted diffusion. And just to show you the example of that, this is a case which was exception that showed the white matter lesions that you can see here very subtly did show restricted diffusion with dark ADC. And this was the atypical case. And I think it may be related to the timing, and I'll show you what I mean by that. While in this particular case, we saw both areas of restricted diffusion plus extensive ADC signal that was bright, which likely represented vasogenic edema. And this particular paper, I think, really nails it. The ADC is very dependent on time. It's extremely dependent on time. What they showed in this study, and there's really not a lot of data about this, is that cases of ADEM that presented acutely, and they defined acute less than 5 days, versus subacute, which was greater than 5 days to about another 10 days, When they present acutely, the ADC is lower, and then it's brighter as you go into the subacute phase. So it all depends on when that child presents to your ER. And you don't always know what the history is. So this would probably explain why we tend to see a mixed response, or could see a mixed response. I also think that you could get restricted diffusion if there's seizures associated with the patient. That can cause a mixed response. But in general, the ADC tends to be bright. So the ADC does depend on timing. Now let's talk about spectroscopy. With spectroscopy, we actually see that myo-inositol tends to be depleted or lower in the acute phase of demyelination. And this is another example of another case in the basal ganglia and thalamus that also shows depleted myo-inositol. And this is an observation I've seen over time. Then there was this study that was published a couple of years ago that actually showed this, where they actually looked at myo-inositol over time and found in the acute phase of ADEM, the myo-inositol is depleted, but as the lesions resolved, the myo-inositol actually became elevated. So their data actually did show that myo-inositol was time-dependent and increased over time. And so this is something that you may be able to use in your practice, but you have to know the timing of the lesion to really help you. Now, myo-inositol is an interesting agent, or a metabolite. It functions as an intracellular osmolate. I think the decreased myo-inositol is probably related to more of its function as an organic osmolate and possibly oxidative stress, while increased myo-inositol is related to gliosis, and this is from animal models. Now, just to show you some interesting cases in the differential, these are both cases of acute viral encephalitis where the myo-inositol is depleted. So I think, and from my experience, we've had quite a few of these cases, and so the decrease in myo-inositol doesn't tend to distinguish encephalitis from ADEM. You can't really use it to help you with that. But what you can do is use it to help you distinguish from tumor, which is an important thing when the child comes in and presents. This is an example of a case that looks like multiple lesions, could be encephalitis, could be gliomatosis, could be ADEM. Not clear. Again, the ADC not that helpful. If you do the spectroscopy, though, you see a very, very prominent myo-inositol peak with NAA reduced. And if you go to the other lesion, you still see the myo-inositol with more NAA. But think about it, gliomatosis can have different grades of tumor that present at the same time. That's common in kids. So when you actually look at the myo-inositol compared and see that the myo-inositol in this particular case is actually in the range of astrocytomas with the NAA relatively reduced, you can make the diagnosis of tumor. And we did. They biopsied this lesion, and this was a high-grade gliomatosis. This is another case that we had, a child that presented with a focal lesion, and initially we did the MRS, the myo-inositol was depleted, and this was at a time that we didn't have a lot of experience with this. We weren't sure, but we suggested encephalitis. They didn't really think it was, so they actually resected it, and the biopsy came back low-grade glioma. So I thought, all right, well, that's not really working. However, the patient in-house started to develop other lesions post-op. And we actually did spectroscopy, again showed this. The pathologist went back and felt that this was actually acute viral encephalitis. And on the follow-up, we can actually see the lesions resolve. The myo-inositol peak actually goes back up, which is similar to what we see with the ADEM. So again, the point is that I think the depletion of the myo-inositol in the acute phase of either viral encephalitis or ADEM is probably a real finding. You can use that to distinguish from tumor. These are just some example of DNET tumors that show very high myo-inositol peaks, and also ganglioglioma and other DNETs and cortical dysplasia that have a high myo-inositol peak. So I think, I haven't really systematically analyzed this, but I do think it's a good observation. Why do you need to be careful? The myo-inositol does change dramatically across development, particularly in the newborn period to the adolescent period. So you have to be careful about how you interpret the myo-inositol. And here you can see the dramatic decrease in myo-inositol that occurs right around birth and then plateaus out. So it's probably useful to actually quantitate your myo-inositol using LC model programs and have a spectroscopist help you when you're trying to make this diagnosis. Now, other advanced techniques, there's a lot of data out there People are trying to use MTI imaging to characterize these lesions in pediatric MS, which is a further area of research. People have done functional MRI in pediatric MS patients to show that they may have actually increased recruitment of left sensory-motor cortex after doing a functional MRI study, and that there are actually differences between pediatric MS and adult MS. And you can see here, when you look at the connectivity, the pediatric cases tend to look much similar to the healthy controls, while the adult cases are showing much more areas of effective connectivity between other areas of the sensory-motor cortex, cerebellum, and motor supplement areas. And it's thought this is why the pediatric cases tend to do better than the adult ones. And this is an area of ongoing research. This is a slide of just using diffusion tensor imaging that Dr. Barakat gave me, in which she shows here that compared to controls and compared to pediatric patients with known spinal cord injury, the transverse myelitis cases actually fit somewhere in between with their quantitation in the setting of a normal MRI. And this is another area of exciting research that will be upcoming. And what I want to end a little bit with is some research our group is doing that's actually looking at cytokine-mediated inflammation in the brain in a group of pre-adolescent twins in a low socioeconomic area, mostly because there's very little data about how does inflammation actually affect the brain. And we've been taking a multimodal approach to actually look at connectivity, metabolites, and DTI in this population, and been able to show preliminary here that there is correlation between certain types of cytokines and also limbic structure and limbic function. And in animal models, it's thought that the cytokines that affect the brain tend to affect the limbic system. And this is also looking at spectroscopy data and with minoxidil, and also with gray matter ADC data, and even doing voxel-wise analysis to actually look at these cytokines in terms of affecting DTI metrics. And I think as we learn more about how cytokines affect the brain, this will help us understand these other disorders. So in conclusion, and I do have a case to show after this, I went over kind of the clinical syndromes for pediatric MS, ADEM, NMOS, clinically isolated syndrome, and transverse myelitis. I think the important thing is to understand these clinical syndromes and then learn the imaging piece as part of it. The imaging plays a big role in distinguishing other mimics and of these pediatric demyelination entities. The ADC and minoxidil levels, if you're using spectroscopy, you can use these to help you, but be aware that these are very time sensitive to the presentation when you're trying to use them. And then I touched upon some of the advanced neuroimaging techniques that we have. And I just want to acknowledge some of the people from my own group, other people who gave me cases, and my research group for some of the slides. And also, I did want to make reference to this actual clinics, which I took a lot of actually figures from, which is coming out in May 2013. And the radiologist that Dr. Schroff was involved with that Canadian study has a whole group of investigators writing chapters. And I've looked at the chapters. It's available online, and the chapters are amazing if you really want to understand all these different disorders. And if you're interested in some of our spectroscopy work, we have a pediatric MR spectroscopy book that's available on Springer. So now let's do the case. And this is a difficult case, so don't feel like if you don't get it, it's okay. This is a case that Dr. Rossi had given me. 9-month-old with 2 days of fever, now with seizures. The child died 48 hours after admission. This is the diffusion imaging and the spectroscopy. So I'll give you a minute to look at that. And so here's the differential diagnosis, and I'll go ahead and let you guys take a stab at it. Let me go back. I can just show you the images again there. And the choices are neurocysticercosis, TB fungal, lymphoid granulomatosis, HLA, primary anginitis of the CNS. And I'll give you another second there. I know this is a tough case. And why don't we go for it? That's what I expected. I really, really expected that, honestly. I expected 20% across the board, because when I saw this case, I was like, are you serious? Like, this is, it's really tough. And so I wanted to show a tough case, especially because this is an important entity. So, and it did actually segue or follow, it's a good follow-up to the really wonderful lecture we just heard about some of the infections. So neurocysticercosis tends to have vesicular lesions, as you saw earlier. And this is just an example of what some of those lesions look like. And there's also the different pathways of the infection. TB, you also actually saw some amazing examples earlier in the talk from before me of what TB looks like. Miliary TB can cause multiple enhancing lesions. You can also get the tuberculoma, which has the rim enhancement, and also vasogenic edema, and also lipids. Now, fungal infection, also Candida tends to be the most causative agent, and I guess it also depends on where you are in the world. Ring enhancement can be seen. T2, they're iso to hypointense. And this is just an example of the fungal case with the lactate and the NAA. And then this is lymphoid granulomatosis. It's an EBV, lymphoproliferative disorder, that shares similar characteristics with PTLD. You can get punctate white matter lesions. You can also get well-formed granulomas. The well-formed granulomas are usually absent, and that's one way you can distinguish that from some of the other infections. And then you also see meningeal and cranial nerve involvement. And I know these are hard. The overlap is pretty amazing. And this is actually the answer for this particular case. And I did want to cover it because it is an important inflammatory hemophagocytic lymphohistiocytosis. It's familiar, acquired, uncontrolled proliferation, and infiltration of benign lymphocytes and histiocytes. So it's an extensive inflammatory response to the brain. And I was supposed to cover inflammation, so I felt like I really should show this case. And you get the leptomeningeal infiltrates, perivascular spaces, tissue necrosis, and the diffusion imaging can be also helpful. And then this is just an example of the last one, which is not correct, which was the vasculitic anginitis case. But to tell you the truth, I expected the 20% across the board. You did a great job. Thank you.